All right, next is renal. So white blood cell casts in urine. The two big ones I want you to think about are acute interstitial nephritis and pyelonephritis. So uremia, so that's from kidney disease where the urea levels are really high. It can impair platelet function, so this can cause an increased bleeding time. But there are 4 manifestations of uremia that I want you to remember that are indications for dialysis. So one is hemolytic uremic syndrome, which is a form of microangiopathic hemolytic anemia. Remember that this is where you get the platelets clumping and then the red blood cells going by and then they shear, which causes thrombocytopenia and anemia. That's HUS, which can also be precipitated by enterohemorrhagic E. coli, EHEC, which is associated with eating undercooked burgers. And then, and usually people with EHEC, when they're treated with antibiotics, such as fluoroquinolones, will lead to HUS, but uremia can also lead to HUS. The second is uremic pericarditis. People have chronic kidney disease with pericarditis, that's uremic pericarditis. Platelet dysfunction, so they can have elevated bleeding times, and if they start bleeding out, or confusion, which is just called uremia, and they would have asterixis with that. Those are the manifestations of uremia, and all of those are treated with dialysis. The top 2 causes of CKD are hypertension and diabetes mellitus. So remember, here, we're going to talk about other dialysis indications, and the mnemonic is AEIOU. So acidosis, which is refractory, electrolytes, hyperkalemia, that's also refractory, intoxications, overload, as in fluid overload from CKD, and uremia symptoms. So the intoxications, there's a submnemonic, which is male, which is methanol, aspirin, lithium, and ethylene glycol. Those 4 substances, when you're intoxicated with them, those are also dialysable. So acute interstitial nephritis, I want you to remember NSAIDs, diuretics, and antibiotics. This is an allergic reaction to medications. The mnemonic is fear. Fever, eosinophilia, azotemia, meaning kidney injury, and rash. So when I think of acute interstitial nephritis, I think of someone who recently took drugs and now they have hematuria with white blood cell casts. Remember white blood cell casts you'll see in either acute interstitial nephritis or pyelonephritis. So when I see white blood cell casts, that kind of makes me suspicious right away. And then if they have a rash on top of that, it's a grand slam. This is acute interstitial nephritis versus acute tubular necrosis, which can be caused by hypoxia or toxins. When you are hypoxic or there's underperfusion to the kidneys, say that patient went into shock, so they had pre-renal azotemia. Remember, if the BUN creatinine ratio is greater than 20, that's pre-renal azotemia. If there's not enough blood flow reaching the kidneys, then the tubules can dry up and necrose, and that's called acute tubular necrosis. Certain toxins can do this as well, but the classic vignette is someone who went into shock and later developed acute kidney injury. And so the key here is on microscopic urinalysis, you will see muddy brown casts. And then this is just treated with IV fluids. Next is the renal tubular acidosis. So remember when you have metabolic acidosis, the first thing you want to do is check whether the anion gap. Is this an anion gap metabolic acidosis or a non-anion gap metabolic acidosis? The anion gap, everyone knows the mnemonic, mud piles, methanol, uremia, DKA, propylene glycol, isoniazid, lactic acidosis, ethylene glycol, and salicylates. But non-anion gap metabolic acidoses, people tend to just get lost on it. But it's so just keep it simple. The 2 most common causes of non-anion gap metabolic acidoses are diarrhea, because you poop out all the bicarb, so that makes you acidotic. Or the next most common one is the RTAs, renal tubular acidosis. And it's not that hard. There's 3 types you need to know: RTA type 1, type 2, and type 4. So RTA type 1, number 1 should remind you of one letter, H. H should remind you of hydrogen. So type 1 is due to under excretion of hydrogen. You lock up all the hydrogen, so you get acidotic. 1 should also remind you of stones. So kidney stones has the letter, you have to spell stone by spelling 1, S-T-O-N-E. So RTA type 1 is associated with kidney stones. Type 2 should remind you of B-I. 2, that's bicarb. You cannot absorb bicarb properly, so you lose a lot of bicarb. That makes you acidotic. Type 4, 4 letters, should remind you of ALDO, aldosterone. So this is hypoaldosterone. So hyponatremia, hyperkalemia. Remember, with aldosterone, it actually, people always remember you absorb sodium and excrete potassium, but people always forget that aldosterone action also excretes hydrogen as well through the alpha intercalated cells. And so when you lose all that hydrogen, you become alkalotic, but that's when aldosterone is working. But this is hypoaldosteronism, so all the hydrogen gets kept. So that makes you acidotic. And the key thing here is that's the only one that has hyperkalemia. So with those little kickers, that should help you. If there's kidney stones, non-anion gap metabolic acidosis, RTA type 1. If there's a non-anion gap metabolic acidosis with hyperkalemia, that's type 4. If it's neither of those, probably type 2. And then remember, if you have a metabolic alkalosis, what's the next best step? The next best step is to check the urine chloride. Why? Because if the chloride is high, right, the urine chloride is high, that means the kidneys are unable to absorb chloride, so this is a kidney problem. And if the urine chloride is low, then this is most likely another problem, a GI problem, such as vomiting. And you vomit out all the acids, so you get alkalotic. Remember that steatorrhea, so fatty stools, when it reaches the terminal ileum, this can bind up the calcium. This is also known as saponification. And when it binds up the calcium, remember that this is a cool concept, because oxalate and calcium tend to bind at the terminal ileum, and then that makes it insoluble, so you poop it out, calcium oxalate. But if the fat is stealing all the calcium and binding to it, then oxalate has nothing to bind to, and it's still soluble, so it gets reabsorbed and goes to the kidneys instead. When it goes to the kidneys, it finds another friend, it finds calcium in the tubules. So that will make calcium oxalate in the kidney tubules become insoluble and make kidney stones. So basically, eating high-fat foods predisposes to calcium oxalate kidney stones. Also, this is a tricky one too, is sometimes people ask, with calcium oxalate stones, do you want to increase calcium uptake or decrease calcium uptake? Because people think, oh, calcium oxalate stones, oh, if you eat a lot of calcium, that'll make more calcium oxalate stones. That's not true. When you eat a lot of calcium, the calcium goes to the terminal ileum, same thing, it'll bind up all the oxalate, and then you'll be able to poop out all the calcium oxalate. If you have a low calcium diet, then that oxalate is free to go back and reabsorb back into the kidneys and make calcium oxalate stones there. So basically, my point is, if someone has kidney stones, you want to have a low salt diet, a low fat diet, and a high calcium diet. And also drink a lot of water to make the crystals more soluble. An elderly male who smokes a lot, who has gross, painless hematuria, I want you to think about 2 things. Either renal cell carcinoma or bladder cancer. Renal cell carcinoma the person will also, on top of the hematuria, will also have flank pain and abdominal mass. If that's true, the next thing you want to do is a CT of the abdomen and then treat it with a nephrectomy. But if the person doesn't have an abdominal mass or flank pain, then the next thing you should think about is bladder cancer, and it's most likely transitional cell carcinoma. This is due to the carcinogens in cigarette smoke. The carcinogens are trapped in the urine a lot, and it tends to pool in the bladder, and that can cause cancer. And then if you suspect bladder cancer, which is gross painless hematuria, in a chronic smoker without any signs of renal cell carcinoma, so no abdominal mass or flank pain, then the next best step is a cystoscopy. Next is a young male with irregularly shaped testicle, a painless mass in the testicle. What's the next best step? Is a scrotal ultrasound. You want to see if it's actually a mass. The mass could be a potential cancer. The next step is an inguinal orchiectomy. You don't want to biopsy it because of potential seeding of the scrotum. So if it's basically diagnosed on ultrasound and then you're just going to remove it. Testicular torsion versus epididymitis. They like to compare these. So remember that testicular torsion is when you get twisting around the spermatic cord and it cuts off the blood supply. This is an acute onset of severe testicular pain, but the spermatic cord is non-tender. If you elevate the scrotum, it's worse with elevation, and the key distinguishing factor here is the cremasteric reflex. If you stroke the medial aspect of the upper thigh, the scrotum under normal conditions will raise, but in this one, that reflex is absent, whereas in epididymitis, it's present. Another key distinction is epididymitis is an infection. So this person will also have fever, but their cord will be tender, and also upon elevation, it's relieved. So those are the differences. But if I had to remember the key differences, is epididymitis will have a fever, and then testicular torsion has no cremasteric reflex. And if you're unsure about the diagnosis of testicular torsion, like in the vignette, the picture is not very clear and they ask what's the best next step, then you want to do a scrotal ultrasound. Say there might be mixed features, but if it's very clear, the diagnosis is clear cut and there's no contradicting, and that's what I mean by clear cut. If all the facts are textbook, but if one of the facts kind of doesn't go with it, like maybe the patient has no cremasteric reflex, but they have a fever, and when you raise the scrotum, it's the pain is relieved, so there's contradictory information, then what they want you to know is what the next diagnostic test would be a scrotal ultrasound, a Doppler, to check for blood flow or to narrow the differentials. If it's very clear, then the next step is orchiopexy, so surgery. And you want to do bilateral orchiopexy because the other one will most likely TORS as well sometime in the future. Epididymitis is also, I want to compare and contrast that with orchiitis, right? Testicular inflammation of the testicles versus prostatitis. So the three of those are all can all get inflamed. And in a young person, the difference is between a young person and an old person. So a young person, the main culprits will be gonorrhea and chlamydia. And in an older person, the main culprit will be E. coli. So you treat them with different antibiotics. By young, it's like someone less than 35, and by older, like older than 35. And sexual history helps too. So a young person, you're going to give ceftriaxone and azithromycin, and an older person, you want to treat with a fluoroquinolone.